Ladies and gentlemen, distinguished guests, and esteemed colleagues, I'm Dr. Nigar, your host for today's event, and it's my great pleasure to welcome you to the second OncoConnect Global Summit today. We have the privilege of hosting a remarkable guest, Dr. Presha Bipath, who will delve in the topic of multidisciplinary strategies to optimize first-line care of patients with renal cell carcinoma. Dr. Presha Bipath is a distinguished clinical oncologist currently in KwaZulu-Natal Department of Health, South Africa. She has completed her specialization in radiation oncology as well as master's in clinical medicine and oncology. She is also the honorary lecturer at the University of KwaZulu-Natal. Thank you so much, Dr. Presha, for being with us here today. And thank you for joining us in this OncoConnect Global Summit. The stage is yours.
Thank you, Dr. Nijar, for including me to be present as part of the OncoConnect Global Summit. I think that it's a very invaluable conference and summit that you guys have arranged. I am happy to present on the multidisciplinary strategies to optimize the first-line care for patients with renal cell carcinoma. As Dr. Nijar had very correctly mentioned, I practice at Nkosi Albert Lutuli Central Hospital, which is situated in Durban, South Africa. So a bit of introduction in terms of renal cell carcinoma, just to elaborate the burden of disease. Renal cell carcinoma is 136.2 per 100,000 cancer cases. Now, this may not necessarily be a very common cancer, as we know that the most common cancers are lung, breast, ovarian, and prostate, but it's still a significant burden on the healthcare system. The median age of diagnosis is around the sixth decade of life and approximately 65 years. It's got a male preponderance with a male to female ratio of 2:1, and it's the sixth most common cancer in men and the ninth most common cancer in female. Now, when we speak of risk factors, and I've chosen to start at this point in my presentation because of the genetics that are associated and the risk factors that are associated with renal cell carcinoma. I think it's important for us to highlight what the risk factors are associated with an increased risk so that we can obviously try and delay this at the point of health-seeking behavior. Now, the most important risk factor is a syndrome called von Hippel-Lindau syndrome. And this is a genetic syndrome which is associated with the loss of heterozygosity of chromosome 3. Von Hippel-Lindau is a tumor suppressor gene, and this is most commonly associated with clear cell renal cell carcinoma. With chronic kidney disease, we know that anything that can cause an insult to the kidney can lead to metaplasia, dysplasia, and then invasive malignancy. This is more so with hypertension and not excluding diabetes, as this results in end-stage renal failure. With obesity, we know that it increases the risk of all cancers throughout, and this is tied into a diet high in fats and a lack of exercise. Smoking is a no-brainer, as we know that this is also associated with many cancers, and it's identified that up to 56 carcinogens are present in a cigarette itself. And this does not exclude vaping and electronic cigarettes. With a family history, we know that a patient would present with a history of a renal cell carcinoma or a CNS malignancy. As we know with von Hippel-Lindau syndrome, a patient's not going to come to you and say that I've got a von Hippel-Lindau mutation, but they're going to present with a significant family history of these associated malignancies. So what is a multidisciplinary team? A multidisciplinary team comprises of a group of specialists or high-level expertise of the healthcare system that are esteemed in managing these type of cancers or for any diagnosis itself. And this team should be part of the management of this patient from diagnosis itself. For renal cell carcinoma, usually the MDTs comprise of an oncologist. This is either a clinical, radiation, or medical oncologist, a urologist, a nephrologist, and more especially a radiologist, and I'll highlight the reasons why this is important. And no cancer MDT is complete without the value of a social worker, psychologist, and a palliative care practitioner. Now, palliative care doesn't necessarily mean that it needs to be instituted at the end stage of the disease. I feel that palliative care principles can be instituted right at the beginning of a diagnosis, and this is also more so with the magnanimous contribution that palliative care practitioners have with regards to pain management and supportive care. So, right at the beginning and presentation, I want to highlight the reasons why an MDT meeting is important. And this is more so because the patient is not going to present with frank hematuria or colic pain or pain typical of renal colic. They're not going to come directly to an oncologist or even a urologist for that matter. Up to 50% of renal cell carcinoma is diagnosed incidentally, and this is because the patient has had either an ultrasound or a CT abdo-pelvis for another reason or another presentation. It's also important to highlight that renal cell carcinoma presents with paraneoplastic phenomena. And these paraneoplastic phenomena that are associated with renal cell carcinoma is hypercalcemia, pyrexia of unknown origin, and erythrocytosis. So any physician managing this type of conditions, especially refractory hypercalcemia, it should then warrant a downstream investigation pathway to seek a renal cell carcinoma diagnosis. The imaging of choice we know usually is a renal ultrasound or a CT abdo-pelvis and an MRI if there are indications for this. A PET-CT in investigating for a renal cell carcinoma is not standard, as we know the tracer is excreted in the renal tubules and the urethra itself, so it's very difficult to assess the local staging with a PET-CT. However, in the event of a metastatic or an indeterminate metastatic deposit, this can be confirmed with a PET-CT. So, why is a radiologist important when it comes to managing or even diagnosing renal cell carcinoma? We know that renal cell carcinoma has a typical radiologic appearance, and this is usually an exophytic appearance. We know that there's corticomedullary and nephrogenic phases on the CT that show enhancement, and it usually has a heterogeneous appearance due to the multiple aspects of necrosis. It is even possible to tell the specific types of renal cell carcinoma, be it a sarcomatoid type, be it a clear cell type, with radiographic features. There have been incidences where we have been obligated to manage patients without a confirmed diagnosis. And this is where we rely heavily on a radiologist to tell us if the mass is in keeping with a non-benign entity like a renal cell carcinoma. Now, it then warrants an investigation, and that is a biopsy if this is possible. The most accessible site of biopsy would be the renal pelvis. However, this is not the most logistically possible way to biopsy. It can very well be due to a biopsy from a metastatic site. And this is where we rely on the histopathologist to then look at the specimen and do the IHC and the testing to then predict whether the origin of the met is from the renal pelvis or renal cell carcinoma or not. We know that renal cell carcinoma is a heterogeneous entity itself. The WHO has classified it into many molecular subtypes and pathways, and this guides the oncologist to decide on the prognosis and can very well be used as predictive biomarkers in the future. Now, the most common subtype of renal cell carcinoma is clear cell, then followed by papillary. And like I've mentioned before, this is not necessarily biopsied from the renal pelvis, but from a metastatic site. And that is when the pathologist will reveal to us if the primary is from the renal cell or not. Now, these are important factors which is important for an oncologist on the histopathological subtype or staining or report. For us, we need to know what subtype it is. We need to know the nuclear grade, as this is important for prognosis. We need to know whether it's a sarcomatous or rhabdoid differentiation, as these are very highly aggressive, and this would obviously dictate further management. We need to know the presence of necrosis. We need to know if there's vascular invasion. And if this is a resection specimen, then it's important for us to put in a T and an N stage. We also need to understand the description of the normal renal tissue that has been resected or biopsy surrounding it. Now, we haven't included a genetic testing system, and this is true for most cancers, and we know that we focus on breast and colon for this, But with the advent of von Hippel-Lindau syndrome, not exclusively von Hippel-Lindau syndrome, it's also a TP53 mutation, a BAP1 mutation, and an SED2 mutation that are associated with renal cell carcinoma. So any patient that has a high index of suspicion, and we'll speak about those that warrant genetic testing sister referral, these patients need to be investigated for a genetic mutation, and not only them, but their associated family members. So what do we do now in terms of managing renal cell carcinoma? And when we look at managing cancers, we divide them into early stage, locally advanced, and metastatic. Now, with early stage tumors, and these are more so the T1 tumors that are node negative, the recommended management is a partial nephrectomy, or in other words, a nephron sparing nephrectomy. Now, this can be done laparoscopically, and it's preferred that it's done laparoscopically as this is a minimally invasive technique. And here we rely heavily on the expertise of the urologist that is undergoing or doing the procedure. But this is also dependent and co-managed with a nephrologist. As with any nephron procedure, it's important to assess the upfront renal function. It's important to decide whether it's a solitary kidney involved or bilateral tumors. And if this is bilateral tumors that are involved, it is possible to still do a nephron-sparing nephrectomy. However, this needs to be tied into their renal function. If it's extensive, and obviously the existing kidney or the uninvolved kidney has impaired renal function, then it's important to note that these patients are then going to be dependent on dialysis thereafter. So the surgical resection also needs to be tied into the feasibility of the operation and the type of operation embarked on. There are other emerging conservative approaches, and this is more so with stereotactic ablative radiotherapy techniques, radiofrequency ablation, and also now with the point of surveillance. Very early stage tumors that have a very good prognosis can obviously be surveilled until they become problematic. And this is more so if actually going in to resect it would cause further damage to the existing renal function. Now, no anesthetic consult will be complete without a pre-anesthetic visit. And this is where the anesthetist will tell us whether it's feasible to undergo an anesthetic for this patient or not. It's important to realize that these patients are not fit patients. They're not well patients. They obviously have a renal function impairment or some dysregulation in the excretion of some of the anesthetic drugs. Now, to do a lymph node dissection or not is very controversial. And it's shown that we shouldn't embark on a prophylactic lymph node dissection. And this should only be done therapeutically for all tumors, T1, T2, T3, T4, or for all node negative tumors. T2 tumors also can be resected laparoscopically with the partial nephrectomy, and the standard approach is very similar to those of T1 tumors. The only difference is they are larger in size. Now it brings us to the T3, T4 tumors, which are usually locally advanced, and these tumors have obviously gone into gyrotous fascia or more so past gyrotous fascia. These patients require resection, a nephrectomy, either a partial nephrectomy or a total nephrectomy, and an adrenalectomy if this has any compromise in the spread of the tumor. A lymph node dissection should be done therapeutically and not prophylactically. And it brings me now to the point of a mural thrombus. Now, mural thrombus is very commonly found in renal cell carcinomas. And this is where we're not dependent on the urologist alone. This obviously needs to be tied in with the vascular surgeon to decide on whether it's feasible to do a thrombectomy. There are controversies surrounding this in that it may not necessarily change the outcome. However, there are some benefits in doing it in terms of local control. What then do we do after the patient has had their tumor resected? Now, it's important to realize that an MDT should not be performed after the resection has occurred. We need to have an upfront MDT discussion. And the reason why I say that is not because neoadjuvant therapy is standard of care. It's actually not the standard of care. Neoadjuvant therapy and downsizing of these tumors is not the recommendation. However, it's important for us then to make contact with the patient and discuss adjuvant therapy options and assess if this is feasible. Now, adjuvant therapy, we know standard, is heavily dependent on systemic therapy with radiation only given if there's a positive margin or a high-grade sarcomatoid type of tumor. So we'll speak more about the systemic therapy options as we divide them into histologic subtypes down the line. Now, with regards to definitive therapy, if for whatever reason we feel that this patient cannot undergo an anesthetic, if we feel this is a medically operable tumor, if we feel that this is further going to impair the existing renal function, there are options for definitive radiotherapy in the form of SBRT and imaging advanced techniques. This, however, is supported by phase 2 data and is considered an alternative approach, but not a superior alternative approach. So what then do we do now with the metastatic disease? We've spoken about early tumors, we've spoken about locally advanced, and now it brings us to metastatic disease. Should we do a nephrectomy upfront or not? And this, to guide us, we've got the MSKCC scoring system, which looks at clinical panels and the scoring system of 1 point for each clinical panel. This includes the Karnofsky performance status, a hemoglobin level below the lower limit of normal, if the time to diagnosis is less than 1 year, if the corrected calcium is above the upper limit of normal, if platelets are greater than the upper limit of normal, and if neutrophils are greater than the upper limit of normal. For each point, we give the patient 1 score. If the patient has 0 to 2 scores, they're low risk, and their survival is magnanimous, up to 97.1%. If it's 3 to 5, they are intermediate risk, and their 5-year survival is about 70%. If it's 6 or more, they fall into the high risk category, and their survival, as we can see, is as low as 31. Now, this is the reason why we need to decide whether doing an upfront nephrectomy is feasible to the patient or not. In my personal opinion, as we know that these articles are dictating our management, and this is in the interleukin era. So we had now then we needed to look at, with the advent of the introduction of TKIs, if doing a nephrectomy is feasible or not. I'd like to bring your attention to the Carmina trial. The Carmina trial looked at sunitinib followed by a nephrectomy, or a nephrectomy followed by adjuvant sunitinib. And as we can see on the Kaplan-Meier curves, there's no difference with overall survival or progression-free survival. When we look at the SIR-TIME trial, we can see that overall survival has a benefit. However, progression-free survival has no benefit with doing an upfront nephrectomy. I feel that from my experience that there is benefit in doing it with patients who are favorable or intermediate risk, who have a good performance status, and have low volume metastatic disease. Now, with the advent of immunotherapy and targeted therapy, we can even do a conversion to a resection, and we'll speak about that a bit later on. We know that the benefits of doing a nephrectomy also has its benefit in the palliative setting with pain and hematuria control. Now, when we talk of systemic management, the ESMO guidelines dictate that we need to look at histology, and this is very, very histologically dependent. And it's divided into clear cell renal cell carcinoma and non-clear cell renal cell carcinoma. As we know, with the risk stratification, there are specific options that I have provided standard for good risk, intermediate risk, and poor risk. We know the benefit for good risk includes your TKIs, which are sunitinib and pazopanib, your VEGFs, which is bevacizumab, and there's still a role for us to use interferon and interleukin. For intermediate risk and for poor risk, it's nivolumab, ipilimumab combinations, followed by your TKIs, which include sunitinib, pazopanib, and temirolimus in terms of your mTOR inhibitors. With your intermediate risk, there's also a role to use interferon. For non-clear cell renal cell carcinoma, we know that these are specific in terms of their subtypes, which include papillary, chromophobe, and sarcomatoid types. Most of them are also TKI dependent, other than sarcomatoid, which is PD-L1 dependent with nivolumab and ipilimumab combinations. And the introduction of chemotherapy is exclusively only for those with the medullary subtype, and this is your platinum-based chemotherapy. There's still a role to use your TKIs in this histological subtype. Now, with a multidisciplinary team, it doesn't mean that the rest of the team needs to withdraw care after the oncologist has then instituted systemic management. We know that the most common adverse events with this targeted therapy includes dyspepsia, altered taste, fatigue, diarrhea, rash, and a mucositis. Now, when we look at the toxicity of these immunotherapy and targeted therapy options, or any toxicity that oncological treatment would lead to, it needs to be graded. Now, with the grade 1 or grade 2 rash, for example, we know that it can be managed by topical means. However, with the grade 3 and 4, you have to consult a dermatology and they need to biopsy or they even need to assess if this is progressing. Usually, we initiate steroids, and if there needs to be other types of therapy, this needs to be reviewed with the dermatologist. More so, even with the colitis. Grade 1 and grade 2, we know we manage conservatively. However, your grade 3 and grade 4, you have to consult a gastroenterologist. You have to monitor input output. You may or may not do a stool culture. You consider your steroid administration and obviously a specific type of antibiotic that may then need to be instituted. It's also true for a pneumonitis. Pneumonitis grade 1 and grade 2, we know we manage conservatively or non-aggressive means. Your grade 3 and grade 4 obviously then needs a consult to a pulmonologist. You need to obviously investigate further. You need to administer steroids, and then you need to monitor the situation to see if it's improving or not. Now, other than immunotherapy, we look at other means of managing these patients. And now we've got the introduction of SBRT, and I'd like to bring your attention to the IROP trial, which has shown that there is an advantage at using stereotactic ablative body radiation in renal cell carcinoma, and this is more so in the definitive setting. Other types of treatment that can be used as alternatives to surgery would include cryoablation, radiofrequency ablation. And now with the advent of immunotherapy, we know that there is potential for us to convert a metastatic patient to a radical patient. There's no reason why, if the patient has a good response to immunotherapy, that you can consider a metastectomy or even a resection of the primary. However, this is also dependent on PS and patient. Now, what is emerging in the data, or what do we need to look out for in the upcoming trials that are looking at renal cell carcinoma? We know that agents are constantly changing. Immunotherapy has taken over in terms of oncology. Data is emerging. TKIs have a good role in its management. We know we've moved on from interleukin and interferon now with specific targeted agents. What I found striking, and this is throughout for most immunotherapy combinations, is that nivolumab-ipilimumab combination has not led to a significant overall survival, and this is for most cancers throughout other than melanoma. So this includes renal cell carcinoma, and this means that you can administer nivolumab alone or ipilimumab alone, and this would also provide a benefit from a toxicity point of view. So what then do we need to do in terms to alerting the genetic testing sister that this is a hereditary renal cell carcinoma? Now we know that patients who are young, diagnosed at the age of 46 or less than 46, have bilateral tumors or have more than a first-degree relatives or 2 or more secondary relatives with renal cell carcinoma need to then be referred for genetic testing. It's not only the patient, but also their close relatives that need to be screened for von Hippel-Lindau, but not exclusively von Hippel-Lindau. They also need to screen for ACTH mutations and Birt-Hogg-Dubé syndrome. So after the patient has been managed or resected or has completely or is in remission, what then do we do? And all patients are not out of the risk. Every patient needs then to be followed up. And a follow-up for these patients include laboratory tests. It includes imaging of the abdomen and usually a baseline CT abdomen. You can do this in 3 to 12-month intervals for up to 5 years and then clinically indicate thereafter. However, if you have patients who have adverse features like a positive margin or a high-grade sarcomatoid type, then you can decrease the interval of surveillance for these patients. It's also important to realize that if these patients had undergone radiation, it's important to monitor for late side effects of radiotherapy. We also need to include chest imaging for surveillance, and this includes a chest x ray or a CT scan annually. So then it brings me to the conclusion of my talk. And I'd like to highlight certain points that we need to be aware of. We know that it's that management approaches are constantly changing and their strategies are constantly changing with newer data and novel therapies. But it doesn't mean that this is not a debilitating disease, and a debilitating disease to the patient and to the healthcare practitioner, which in my words means that renal cell carcinoma is all hands on deck at all points of management of the patient itself. Thank you for your time, and I'd like to open the floor up to any questions.
We have received some questions from our audience, and we would like to share these questions with you and hear your thoughts on these questions. So the first question is, how has the introduction of immunotherapy and targeted agents changed the MDT strategy in managing renal cell carcinoma?
So, with the introduction of immunotherapy and targeted therapy, we know that we've moved on from interleukin and interferon in their era in terms of managing these patients. Like we've said, there is a potential for conversion to resection, which means that a metastatic patient with limited metastatic disease can now then be converted to a radical patient if they have a good response to immunotherapy. So post immunotherapy and systemic therapy administration, you image the patient, and then you can still get on board your multidisciplinary team, the nephrologist and the urologist, to then assess if a nephrectomy is still feasible, and not necessarily only them, but even a cardiothoracic surgeon if they've got limited metastatic disease in the lung. We also know that with the side effects of immunotherapy, we have a whole host or a whole cocktail of side effects. As much as they quite magnanimous in their approach, they're also associated with some toxicity. So we need to co-manage the colitis or the rash or the pneumonitis with the pulmonologist or a gastroenterologist. So in that sense, your multidisciplinary team members expand to include a more physician base.
Thank you so much, Dr. Presha, for providing an answer to this question from our audience. Also, we have a second question. The question is, when is the ideal time to adopt an MDT approach in the management of renal cell carcinoma?
So the MDT needs to be instituted even at presentation. We know that most patients will present incidentally. We know that not all patients can undergo a biopsy. We know that not all biopsies are done from the primary site. So that is why even at presentation, you need to start including members to your multidisciplinary team panel so that whatever management strategies are decided upfront and followed through in terms of patient care throughout.
Now, moving on to our final question of the day. The question is, with newer and emerging data, along with systemic management options constantly evolving, what strategy is of significant importance?
To me, it's an upfront nephrectomy in the metastatic setting. And I feel that this, even with the advent of imaging data, previously it was advocated for those with MSKCC, intermediate or good risk. I feel that in the principles of palliation, the kidney is not something that can be very easily radiated. And as much as we have SBRT and ablative techniques, it's still associated with toxicity. There's the role for a nephrectomy in terms of palliation of hematuria and pain control. So this is something that we need to focus on. We also need to include the fact that multidisciplinary team management needs to be instituted for the metastatic deposits like a spinal metastases, even hypercalcemia management. These type of approaches are standard throughout and irrespective of the newer novel therapies that have been introduced.
Dr. Presha, we sincerely thank you so much for your great presentation and also for your time and effort you dedicated in contributing to our OncoConnect symposium today.
You're welcome. Thank you for including me as part of the Global Summit.
Thank you so much, Doctor. And to our audience, thank you so much for your thoughtful questions and for your active participation. We hope today's discussion has enriched your understanding of this critical medical field. Thank you so much. See you soon. Goodbye.